And during the peer support group meetings, the South coordinator would facilitate a discussion about challenges CHWs were facing in providing CCM, discuss any supervision issues that the in-charge of community health had raised. They would also then review and compile CHW support reports, again in a smaller group setting, and then the CHWs would together plan and coordinate any health promotion activities, support to a vaccine campaign together. The program ended in 2011, and final evaluation of the project was conducted that year in August. It was a participatory and mixed methods evaluation that used both qualitative and quantitative data. And we also, as well as sort of participant observation, and I'll be talking about the findings of the final evaluation today, specifically as they relate to the peer support groups. What we found through the evaluation was that the peer support group model implemented under the program really served as a very manageable and valuable sub-level of CHW organization that we found was associated not just with improved opportunities for CHW supervision, but also that increased CHW performance and also led to increased social capital. So I'll go through some of these findings now. First, just in terms of CHW supervision. So as you'll remember, the default structure was that the in-charge of community health was meant to conduct quarterly supervision visits to the hundreds of CHWs in her catchment area. Peer support groups lessen transportation and logistic and time barriers by enabling supervision access to CHWs at an intermediate level between the health facility and the community, during which they could address many supervision tasks in a small group setting. So while the CHW peer support groups were facilitated by the self-coordinators, the health facility in charge also had an opportunity to visit these support groups herself and conduct many of those same supervision tasks. In addition, the peer support groups also provided an opportunity for informal peer supervision. Health facility personnel attested that this peer supervision actually helped to compensate for health facility staff limitations. One of the medical directors of one district said that there's a difference since the establishment of peer support groups. Members can train each other, self-control, and do reports. You can follow up regularly with everybody at a lower cost. We also found that the peer support groups had an impact on improved CHW performance, and we're defining CHW performance by the domains of CHW productivity, reporting rates, and also motivation. So I'll start with productivity. So we're looking at two domains within productivity, both the numbers of treatments given, as well as the number of household visits conducted. We have access to national level data on the total number of treatments given in the country over the last 12 months of the project. And we find that CHWs in Cabeja-Juana supported districts provided a full third of all of the treatments given in the country, while we only cover 20% of the population. So proportionally, we're providing way more treatments than expected based on the population. We also found that the CHWs in our area were conducting many more home visits for health promotion. This is typically not a role that is formally expected of the genome providing CCM. But they averaged about 44 home visits per village per month as compared to a lesser range in other districts. So we did find that these contributed to sort of improved productivity, higher levels of productivity. There was also a consistently very high reporting rate. CHW reporting was around 93% throughout the life of the project, which is quite high. And we found that during the final evaluation, this regular interaction between the CHWs and their supervisors really helped to improve CHW reporting. It certainly eased the burden of work on the self-coordinator, who could do the reporting in very small group settings as opposed to having to do up to 100 or 200 CHW reports on a quarterly basis at once. And then finally, it had a very, very high impact on motivation. We kept using the words energy multiplying, and what we mean by that is that the peer support group meetings were a time for CHW to come together, to plan activities, to get ideas from each other, and really to keep each other motivated to keep doing their work. And we do know from the literature around CHW motivation that that sort of peer level of engagement and encouragement really does help with intrinsic motivation. Attrition of CHWs was of 1.2% over the life of the project. Unfortunately, the literature has not a lot defined around CHW attrition. I think the norm, what's documented, ranges from between 3 to 77%. But we had 1.2%, which is a very strong rate. And just finally, in terms of social capital, this is sort of a broad term that we are using to encompass a lot of the positive externalities that we found around the peer support groups. Frequent interactions between CHWs, sharing experience around learning and sharing, lots of solidarity between the groups, and no CHWs wanted to underperform. We found that these small group settings led the CHW to know that every single one of them was being accounted for and followed, and not sort of lost to the general, group of CHWs under the health facility. They say, one quote from a CHW from the final evaluation was that things work well because there's small groups, so results are more visible because everyone assesses their neighbor's performance. In fact, there were several accounts of peer support groups, or CHWs and peer support groups, that suggested that maybe one CHW stepped down if they didn't feel like they were working as well as they should. So just to close, in terms of potential integration with the national community health system, this is a triangle that just sort of shows it with the MOH community health desk at the top, district level, health center level, the cell level, and then in yellow there is the insertion of the peer support groups, and then finally the village level at the bottom. Some people might posit that in addition to the regular sort of cell level quarterly meetings, these peer support groups could appear redundant and maybe another source of CHW meeting fatigue. However, qualitative data that we collected during the final evaluation established that CHWs actually do view the cell level meetings and the peer support groups meetings as different but complementary levels of a consistent system of organization and CHW support. So one CHW said, the peer support groups allow us the chance to solve many of the problems before we get to the larger CHW meeting at the health facility. Members actually talk more freely than they would at the cells. So I'll just close by summarizing the conclusions from this case study. First of all, as we all know, CHW supervision is a challenge across countries, especially when there are such high ratios of supervisors to CHWs. We also found that compared to CHWs working independently, CHWs working together in groups actually develops a stronger commitment to implementing health activities and to provide greater peer support to jointly find creative solutions to problems. The MOH stakeholders at all levels, from the district to the health facility, on down to the CHWs, found the peer support groups as an effective mechanism for CHW coordination and meaningful engagement of the CHW at the actual community level. And finally, as the MOH community health policy continues to expand and evolve in Rwanda, we believe that key elements of this peer support group model could be integrated within the framework of existing community health structures in Rwanda. Thank you.
Okay, thank you, everyone. Basically, what I will be talking today is a work done in Benin under basics. Some of you in this room are aware of basics that ended some time back. And we did an experiment almost on reaching quality improvement in this country. So, okay, it's Benin. I don't need to tell you about Benin. Well, we worked in 5 health, the basics project worked in 5 health zones in the northern part of Benin. I have to say that when we started in Benin, this was the first experiment of iCCM in Benin. Until then, there was no iCCM, there was only a bit of malaria here and there, sprinkled in there, but really, in reality, no iCCM. So we had to put the package together And there was some resistance online, as usual, factoring for being used by lay people, but we get going. So really the training shows the community, the wage, the project shows the workers, or the communautaire. They were trained and they were put in place and left there. So what we did after 3 or 4 months from the training and placement of the workers, we went in and did a post-training assessment. Post-training assessment in which we use a triangulation. Health worker interview, with worker interview, with observation, practice, and exit interview to understand their counseling skills. Although I will not be talking about the exit interview here. Okay? So we found out, it was not a big surprise to us, that there was some weakness in their competence, in their knowledge among the community workers. I have to say that since it was a new package, many people start doubting again about the use of community workers in doing iCCM. The rumors were going out. This was basically 5-6 months after the iCCM package has been going on. The ministry, the usual discussions we hear even today. So we decided to come in and propose a quality improvement work through supervision. So this was one of the districts there, reality, and we get going. Now, what was the package, the component of the intervention? I would like to start from the last point here. Establish 6 local quality improvement teams. These teams, basically, it was clear that the problem was between the usual weakness, the link between the community workers and the health center. That was one of the issues where we thought we could use in order to improve the quality of care. So we start with the ministry, there were NGOs involved, local NGOs, Beninese involved, establish teams of stakeholders. In this case, the stakeholders who were community workers, the supervisor, and community leaders. In this case, the community leaders, community members. And we said establish 6 local teams, but each team was big enough to include 2 or 3 sites. Okay? So, but also allowed to have a discussion, a meaningful discussion among themselves. So these teams came up and they had a coach that was outside the team, that was trained, the coach was trained, came in, and they were, the role of the coach was basically to discuss the role of the team and the goal of the team. Okay? What happened that 2 things came up. They discussed about doing a bit more quality group supervision, or in French, supervision groupée, and individual coaching on site. The major point here, the point here that each of these 2 lines of supervision were clear. The task for each supervision was clear what they were trying to do. Okay? So, I kept saying there were problems in quality of care. So, this, what we did, that was the first clinical assessment, the first one. So, this is just the observation, okay? We did the triangulation at the end, we just focused on observation. So, we want again because they understand the practice in the real life. And we did 2 assessments. One after 3 months and one after 6 months. And you see the upward trend. I had other indicators, but I just decided to use these ones for the presentation data science, I think that applies as well. But you see that how the trend nicely went up. It's normal. There are very few work done at community level using this quality improvement. But having used the quality improvement at health facility level, this upward improvement is quite normal because you put coaching in, you have learning sessions where you bring the community focus together, discussing their problems. They realize they are not isolating their own problems. They share common problems among themselves. So for them it's a moment of discussion and finding out solutions to their own problems. What I don't put here that is always a classic is data science. The knowledge of data science, and of course, if you don't have the knowledge, the practice is even lower. So it's not suggest there is such a but I think that is clear. So we try to come up with some best practice to keep going. This was towards the end of the project, so we were concerned about sustainability of this best practice. So we tried to put together a package to be followed up by the ministry or where we were going to continue to work in those areas. So it's clear that the nurse needs to be motivated. Now, in Benin, motivation means sometimes coherence only. But not only Benin, I think it's a classical, a cliché. But I think what we mean here by motivation is beyond financial incentives. We focus on supervision, what this really means, and how to have them very close to the community workers. The second point is, I believe is one of the most important ones. Usually these CHWs are left on their own doing the work. And I think we prove that coaching these people, we all know these are low literacy people, very few years of schooling, is essential for them to minimize the erosion of the skills of the competencies they acquire during the training. Putting this CHW together, discussing it, making sure they realize their problems not their own problem, but these are shared problems, helps to come up with some common strategies or discussion among themselves. And that we believe is quite important. That this has helped a lot, at least from what we have gathered after the problem. Okay, we are at the lessons learned. Clearly, motivation of the CHW are essential. Now, what does mean? Means that they understand what they're doing, but there is also something beyond motivation, beyond the knowledge. In the issue of financial motivation, that will be important. There's always expectations. And we had some discussion. We were not in the best position for that one, but we understood that it was something very, very crucial for the people and for the future of the project. The second point I put there because, as I said in the beginning, people were starting doubting about the possibility that the potential that CHW could do the work. Clearly, this showed many people they were capable of doing it. There was some change of heart around. I don't know how many hearts we were able to change, but some were changed. And as you know, iCCM is always controversial. It's always something we never end until we have some tangible results in scaling up. The third point, I think, for me, was a lesson learned for myself. If I would go back to Benin and I would start again, I would do a different approach. What we did that time, we started running, like the Ethiopians running. It was a field project, so we had to deliver. However, before starting next time, I will do a readiness to go. I will really sit down with the ministry, with the health centers, the ones that will get the headache, the nightmare sometimes, the problems at the end. When really it's now we have created another system, it's your problem. I think this is, for me, is an ethical issue actually. And for me, it's extremely important that this discussion, not only in engagement, but having a plan from the beginning, how this can move on and can go on to the next phase, is, for me, is vital. It's almost a continuous note. It's vital. Okay? So, I think this is my opinion. Clearly, the cooperative brought in a team approach that was not seen in Benin, at least at community level, which